Well, good afternoon, good evening, good morning, wherever you are in the world. And thank you for joining our Hyperfine webinar. I think we have an exciting discussion this afternoon, evening, or morning. We're going to be talking about point of care testing in hydrocephalus, a case for change. And we have a phenomenal speaker, exceedingly experienced in hydrocephalus, pediatric neurosurgery, as well as the use of the Hyperfine Swoop MRI. Dr. Jeffrey Leonard is the Chief of Neurosurgery at Nationwide Children's Hospital in Columbus, Ohio. He is also the Wolf Foundation Endowed Chair in Neurosurgery and a Professor of Neurosurgery at The Ohio State University. And it gives me great pleasure to introduce Dr. Leonard.
All right, thank you, Eddie. Well, I see we've got quite a number of people online, and I'll first talk about thanks for the opportunity to come and talk about hydrocephalus, talk about how we perform imaging, and really talk about what I think is going to be a revolutionary change in the way in which we care for this chronic disease. I really became interested in this because, first, before we get started, I'd like to say I do have a relationship with the company, but that's not why I did this. I did this because we want to talk about hydrocephalus. We're going to talk about some of the epidemiology, the types of hydrocephalus, talk about the clinical signs, go for the ophthalmologic assessments, radiographic signs, talk about the management of hydrocephalus and the kinds of things you need to look out for, as well as the Hyperfine workflow that we've been working on for a while here at Nationwide Children's Hospital. And then talk about some of the long-term care options with this, and talk about some of the things that really are germane to how I think Hyperfine is going to improve the workflow and care for the patients with this disease. Now, the reason I thought about hydrocephalus in terms of Hyperfine is that this is really a chronic problem. This is a disease process that is probably the most common thing that we see in pediatric neurosurgery. It is a disease that is probably in the larger practices about 30 to 50% of the cases in pediatric neurosurgery. These patients range from newborn to greater than 70 years of age, where the types of hydrocephalus that you see also change during that period of time, where the newborns have what we call interventricular hemorrhage, or hydrocephalus of prematurity. And when you get to be older, you have NPH, you have things that where people have problems with dementia and memory, and can really have significant improvements if they're both diagnosed on time and the shunt is followed over the appropriate time frame to really determine that there is no further injury to the central nervous system. Now, the reason Hyperfine is important is that imaging changes are commonly relied on to determine whether someone has hydrocephalus or whether someone has evidence of a shunt malfunction. Though hydrocephalus it should also be stated that 20% of patients with shunt problems in this particular disease process do not have imaging changes. And what I'm showing in this video that everybody is watching is that there are alternatives to shunt placement as well that really are very important, because if you can avoid the placement of a shunt because you can perform another procedure, it does give you some opportunity to really change the patient's trajectory and really make care for them much easier as they get later on in life. First of all, before we really get too much into it, I'd like to talk about hydrocephalus and really give you an overview. Hydrocephalus, and it's important because this is a common misunderstanding that we have in patients that have hydrocephalus. Now, hydrocephalus by definition is a combination of radiographic signs of ventricular enlargement and clinical signs and symptoms of elevated intracranial pressure. And by signs or symptoms of elevated intracranial pressure, I mean they have evidence of increasing head circumferences if you're really young. They have nausea and vomiting and decreased mental status. They can have cranial nerves can start to be a problem, including the sixth nerve palsy being one of the most common. If these symptoms are associated with changes in ventricular size, that's what we call hydrocephalus. We distinguish this from ventriculomegaly, and we'll talk about why this is important later on, is because ventriculomegaly by itself is just the radiographic evidence of ventricular enlargement with no symptoms of elevated ICP. This is especially important in the really newborn children, because you're trying to determine whether this represents ongoing neurological injury or these ventricles are just bigger than they normally should be. What I'm showing off to the right side is transependymal flow, which we'll cover a little bit later in the talk, which is a radiographic sign of hydrocephalus. Now, before you talk about hydrocephalus, you really have to understand the two various etiologies. The two various etiologies are both communicating and obstructive hydrocephalus. Now, communicating hydrocephalus, by definition, is blockage of flow outside the ventricular system. This can occur because of inadequate CSF absorption. The arachnoid villi that are present in the superior sagittal sinus really do not absorb the CSF at a rate that keeps up with the rate of production for the choroid plexi. There's also evidence of CSF overproduction, which is a much less common, which can include choroid plexus hyperplasia or choroid plexus tumors. This is important because shunts by themselves do not drain. I recently had an abstract and poster at one of our section meetings where I was participating with another device that we were able to calculate how much flow is actually going through a shunt. And what we figured out is that the entire rate of CSF production in a lot of these cases is not being drained by the shunt, just a portion of it. Now it's higher in obstructive hydrocephalus, but sufficiently lower in communicating hydrocephalus that it's just, the shunt is just serving to balance the system such that the fluid doesn't accumulate and cause ongoing neurological injury. Now, the obvious other etiology for hydrocephalus is obstructive. This can be caused by blockages throughout the ventricular system, including aqueductal stenosis, posterior fossa tumors, third ventricular tumors, colloid cysts, or other systems of pathology that we see throughout the ventricular system that could cause our CSF not to drain as it should. Now, I'm going to go through next a few etiologies of hydrocephalus and demonstrate that, and the reason to do this is because our imaging studies need to be able to differentiate and image some of the problems that are associated with each of these particular types. Now, one of the most common things that we see at Nationwide is communicating hydrocephalus or hydrocephalus of prematurity. Now, these are ultrasound images of both grade 3 and grade 4 IVH. We need to see whether ventricular systems enlarge in grade 3 and grade 4 IVH, and we need to determine whether there's evidence of blockage within the ventricular system, which can sometimes happen, either compartmentalization of the fourth ventricle or other things that are not particularly well imaged in IVH. Myelomeningocele, another very common etiology of hydrocephalus, especially in the developing world. And as you can see here, these can often have numerous abnormalities. These can have the common MR findings, including the beak tectum, the low-lying torcula, and those can also have dysmorphic ventricles as well. This particular one has colpocephaly in the back. So we need to be able to image and discern all of these abnormalities if we're going to adequately make the diagnosis of hydrocephalus. And I should also say that our recent MOMS trial also said that we were able to tolerate bigger ventricles for children with myelomeningocele, and fewer of these children are actually having shunts placed than, say, 20 years ago. Another common obstructive hydrocephalus in pediatrics is aqueductal stenosis. Now, for those of you that can see my pointer, the tectum here is dramatically enlarged. This is caused by evidence of a tectoglioma, and the CSF is going to flow through the aqueduct, which is here. And as you can see, there's a cupped-like appearance of the aqueduct, which demonstrates that the aqueduct is sufficiently blocked at this to cause hydrocephalus. Now, this is also illustrated by the enlargement of the temporal horns, and I'll also demonstrate a MR finding that has to be able to be detected on your imaging study, which is depression of the third ventricle. And through this, the third ventricle is depressed. The lamina terminalis is ballooned out. And as you can see here, this demonstrates obstruction within the third ventricle. Whereas if you were going to treat this patient, you would perform a third ventriculostomy and make a hole through the bottom of the third ventricle. The other one is we can have obstructive hydrocephalus with fourth ventricular outflow obstruction. This occurs most often for us in cases of IVH, where you have scarring of the outlet of the third ventricle at the bottom. This happens when you get dilation and cranial nerve findings, as well as vital sign changes. This is not well imaged using ultrasound. You're left with either choosing to send them through a MR, where you're taking a 26-week-old infant, taking them down to an MR scanner, and bringing them back to the NICU. And the convenience of Hyperfine is that they can be imaged directly at the bedside. Now, let's talk about how big this problem of hydrocephalus is. This is one of the most comprehensive articles that I've seen showing age-specific global epidemiology of hydrocephalus, a review and meta-analysis in global birth surveillance. The graph under here shows the incidence within Asia, North America, Europe, and South America, as well as Africa. What you can see here is that the incidence is especially low within North America and much higher in Europe, South America, as well as Africa. And this is most commonly due to the prevalence of spina bifida associated hydrocephalus. As you can see, this red bar indicates the contribution compared to all the other either infectious or non-spina bifida associated hydrocephalus associated with the prevalence of hydrocephalus. And as you can see, the global prevalence of hydrocephalus is 85 per 100,000 births. This is also prevalence by age, where in pediatrics it's 88, adults it gets lower, and the elderly it gets much higher, which can also indicate that the use of imaging throughout the age spectrum is going to be quite significant. So why do we care about how we image these children? We care about why we image these children because we don't like them to get radiation. This is a chronic disease process. And what this shows is over the course, and as you can see, age at shunt, you can see the number of CT scans performed can get quite large. With the youngsters here, when their age at shunt is less than 1 year of age within this 0 to 12 months, you can see they're getting a whole lot of CTs. And this is not, why is this important? This is important because they don't get low-grade tumors. They don't get arachnoid cysts. They get high-grade tumors when you deliver radiation to a greater frequency, especially in these really young kids. This is also another meta-analysis showing the cancer rate increases significantly with increased rates of radiation. Now, this is from some studies in 2012, 2001, as well as 2007, showing substantially increased risks of brain tumors due to radiation. Risk of brain tumors for some of these studies, only significantly higher in the exposed cohort. Fatal cancer per CT scan is significantly greater in under 20 years of age. There is estimated approximately 500 per 600,000 patients died from radiation-induced cancer. This also for lifetime risk attributed per 10,000 CTs, and as you can see for tall tumors, varies according to age and gets much greater, especially in the really young kids. And relative risk of brain tumors in this study from 2012 shows 2 to 3 head CTs triples the risk of brain tumors for these children. Now that's a risk that we can't avoid. And that's one of the things that put me onto or made me significantly interested in the development of Hyperfine. This is an example case to show you what I'm talking about. This is a 7-month-old, the next 27-week premature infant with IVH, hydrocephalus and seizure disorder. And what I'm showing here is a CT scan showing multiloculated hydrocephalus. They have loculations on the left here, which is showing at least 3 cysts that we can see, and another one on the right. This is important, but because this child also has, as you can see here, their very complicated ventricular system. This child had multiple ventricular peritoneal shunt malfunctions requiring bilateral shunts, had a ton of CTs and a ton of MRIs. They had an intracoccal shunt infection, also something that caused both the multiloculated hydrocephalus and can significantly cause problems with decreased cognition as they get older in life. Multiloculated asymmetric ventricular systems and multiple shunts absolutely increase your the number of imaging studies that you obtained. He presented to us with multi-layered hydrocephalus, increasing head circumference as well as listfulness, needed a shunt revision. So the question is, does your imaging study actually show you what you need to show? We ended up imaging this patient and doing a stealth at both the CT scan and MR, and showing that we needed to do some endoscopic fenestration. Here it is in the back, or in the lower panel, showing that I'm punching holes in a variety of these fenestrations. And I'd like to also point out, this is once again a CT scan, showing that we have managed to communicate all the ventricles and decompress the resulting hydrocephalus. Is overall a very good outcome. Now, pediatric hydrocephalus, it gets important when you talk about management. There's a high risk of shunt failure due to either malfunction or infection. And the rates of failure and infection can get up to 40 to 50% within the first 2 years after insertion. This means we're going to require imaging studies, especially in the really young kids. Now, the risk of shunt infection is 4 to 17% per procedure, highest during the first 6 months after insertion. Multiple shunt revisions increases the risk for future infections. And what I'm trying to say is that we do have situations where we need to repeatedly image these children, and trying to reduce the amount of radiation that we expose them to is going to be exceedingly important in the children's overall outcome. How do we manage them? We often use them often use ventriculoperitoneal and ventricular atrial shunts. We have valves. We have both fixed pressure valves, and these are a couple that we use here at Nationwide Children's Hospital. We use the delta valve as well as the strata valve. These are important because these are magnetically induced valves. We use them because we have to determine their settings. And in the standard MRs, we have to recheck each of these valves after the MR scanners. And we have radiographs that we have to go through, especially in, say, the Codmans, where we have to really determine both in X-ray, and sometimes spend a considerable amount of time in X-ray determining where the valve is set at. So it's exceedingly important to have a system that is both convenient for the patient and doesn't create undue problems when you're trying to manage the hydrocephalus. Shunt failure occurs, it's less likely after 6 months. We also talk about the alternatives, delayed failure for ETD. You have to determine whether, in your imaging study, whether you have a failure from the alternative to shunt revision. Because of this, routine clinical follow-up is necessary, and the use of surveillance unit is necessary, but highly variable depending on what institution you're coming from. Now, in order to measure this, I'd like to say that how do we do this, and how do we determine what are the best outcomes? We have what we call the Hydrocephalus Research Network, and this has done a tremendous job in really guiding and changing the way in which we care for shunts. They have multiple multi-institution protocols that really help with determining risk factors for shunt malfunction, and how we can work to modify our risk factors for treating these children. We look at hospital care and utilization of resources, including utilization, charges, comorbidities, and deaths. We establish these outcome measures because we all want to make sure that we are doing as best as we can in the treatment of these children. We also evaluate alternatives, because if we're going to say that we want to do endoscopic third ventriculostomies, which I'll talk about a little bit later, or as well as choroid plexus cauterization, we have to look and see whether these procedures actually work and lead to further decreasing the amount of times these children have trips to the OR or trips to the hospital, or their risk of infection, all of which we evaluated within this study done by the Hydrocephalus Research Network. We also talk about reinfection, because once we all have reinfections, and it can be highly variable depending on your institution, but we want to make sure that once we have it, we want to make sure there's no abscesses that occur. We want to make sure that we have no evidence of ventriculitis, so that when we do it, we treat them right the first time. We try. There is significant variation existing in both the surgical and medical management of CSF infection. This was one that determined how do you reduce your initial CSF, your reinfection following a shunt infection, because this is important, because these children with multiple shunt infections, as I showed, develop multiloculated hydrocephalus, which is, you want to avoid that, because then you wind up with multiple shunts, and this is just a problem for these children as they get later on in life. We talk about reduction of ER visits because, as some of you know, once they go to the emergency room, if they don't know much about it, how to manage hydrocephalus or don't know the patient, you're going to get imaging studies and CT scans because MR in most institutions is not available on a 24/7 basis. So the other thing we did to manage the imaging is we reduced ER visits, and we established both 24. We established 5 days a week visits to our clinic, and we established criteria for which patients would go to the emergency room versus those patients would go to the clinic. And this is important because we were able to reduce our visits from 10 visits per month to 4 visits per month. We reduced it by over 60%. What this does is it saved us a bunch of money because Medicaid, and this made us extremely popular in our particular hospital. We also have patients that have multiple systems. Imaging frequently increases in this particular. This is a 24-year-old that I manage here at Nationwide Children's Hospital. He had headaches since his last revision in 2010 and his last one in 2009. He has a right and left ventricular peritoneal shunt. And as you can see, he's got essentially no ventricular system. And once again, how is he repeatedly imaged at 24? He had over 50 CT scans at this age, which to me is not the situation I want to get into. And which is why I'm working with Hyperfine to make this available and try to reduce the incidence of CT scans in the treatment of these patients. Now, he has not developed any secondary malignancies, but he continues to have problems with headaches. And by using MR imaging in these particular patients, we were able to demonstrate that his headaches bear no relationship to the presence of or functioning of his VP shunt. We're able to reduce the amount of imaging that he was obtaining and reduce the number of shunt revisions that he has been undergoing. So overall, a successful story, but I would also like to point out the hazards of these repeat CT scans. Okay, the other thing that your imaging study needs to actually be able to determine is, does this patient really need a shunt? Ultrasound doesn't show the floor of the third ventricle, does not show you very well where your level of obstruction is. You need an MRI scanner. And this is the same patient showing both ventricular dilatation, but this child actually has obstruction at the aqueduct. You get a little bit of depression of the floor of the third ventricle there, as pointed out by the arrow. You get a very clear cupping of the aqueduct there, shown by the white arrow in the back. The child had no symptoms of macrocephaly, and a flow study showed no flow in the aqueduct. So the question is, what do you do in this particular situation? Now, I did point out this is a 2-year-old, and what we ended up doing in this situation is we gave him a third ventriculostomy because you're at this age, your risk or success rate for a third ventriculostomy is sufficiently high enough to warrant performance of that procedure. And he's been doing well without the need for placement of a ventricular peritoneal shunt. Now, for those of you that don't know what endoscopic third ventriculostomy is, this is one of the potential scopes that we can use. We use either a rigid scope here or a flexible scope. This depends on the practitioner. We come in through a small burr hole in the brain and are able to pass through the endoscope, which is parked at the bottom of the third ventricle, seeing here. We're able to pass something to puncture the floor of the third ventricle and balloon dilate this, and then even pass the scope to visualize the basilar artery and all the third nerve, which is going to be present here, as well as the multiple perforators that are present supplying the brainstem. You have to be able to identify and avoid these potential hazards so that you don't have an unforeseen problem with the third ventriculostomy or a potential disaster that you cannot recover from. And as other authors have shown, the long-term reliability of an endoscopic third ventriculostomy, it does quite well. As you get up above 2 years of age, this model predicts the success and the reliability for an ETV. At greater than 2 years of age, this is almost 80% effective. It gets lower as you get further down, including the 1 to 6 months age, is 0 to 1. Now, this is where we have been adding the choroid plexus cauterization in hopes of increasing the success rate and see how that matches up with placement of a ventricular peritoneal shunt. This is overall because your imaging studies need to be able to show that this is actually a viable option for these patients, because if this is successful, you can actually avoid placement of these shunts for the in these really young kids for the foreseeable future. So how do we determine hydrocephalus? This is sort of the next phase of this. We talk about radiographic measurements. And these are sort of some of the, for those radiologists in there, these are some of the standards. The frontal occipital horn ratio, or FOR, as you can see here. We look at Evans index, which is, as you can see, I'll save the reading. But what I'm also doing here on the right side is showing that you can calculate the same things with the Hyperfine image. And you can get some of the same measurements and determine these same ratios using a standard Hyperfine imaging that I've been able to do here at Nationwide. It's important because it shows that it's doable, and it's doable in imaging for a patient. I believe this particular patient was 4 years of age. So you can do it. And more important, you can do it without sedation. So the other aspect of this is ventricular volumes. Now, there's some studies that show that you have at least a 15% change in your ventricular volume before you actually see radiographic change. This is one of the big things that I was getting when I was getting exposed to Hyperfine, was that it was exceedingly important to determine what the size of the ventricles were. So how do you do it? A lot of times the radiologists will use the term close clinical correlation is warranted. Now, I'm not picking on the radiologist, but you know that when something is very dysmorphic, that's very hard to interpret. And so what really got me interested in this is the calculation of ventricular volumes. And can we do this in a way that's automated and is sufficiently fast enough and to really be of value to the clinicians, to provide almost instantaneous or very real-time feedback, so they're able to make clinical decisions when they're faced with patients that have either worsening neurological function or nausea, vomiting. They also have the flu, and you're trying to determine whether it's the flu or it's actually changed in ventricular volume. This particular study that was done showing that the ventricular volumes grow in childhood. These are normal change as the children get, so this should be like, you know, obvious to everybody, but this gives you published in 2020, this gives you a very realistic estimate. And what they're saying on the right is you're seeing how they ended up calculating the ventricular volume using some of the images that you see before you. This is another showing the problem with white matter. DTI patterns consistent with axonal compression, enlargement in total ventricular volume, and increase in shunt revisions associated with higher fractional anisotropy and radial diffusivity. Intellectual ability did not significantly correlate with ventricular volume or shunt revisions. So what they're able to show here is that with ventricular volumes, they're able to show that white matter injury is occurring. So this led me to really talk about the utility of this in the management of hydrocephalus. So this is another sort of what you have to show before you really, can you change your ventricular volumes significantly and detect them by actually changing your volume of CSF. Now this is another authors in 2016 showed that drainage of 40 cc's in 23 adult patients showed that quantitative MR performed at 30 minutes, 4 hours, and showed your CSF volume decreases at 30 minutes. There's also significant associated between change in ventricular volume and what you're seeing in the brain parenchyma. So what is seeing is we can actively, by removing a defined quantity of CSF, change your ventricular volumes. So why can't we use the same thing to detect changes in pediatric hydrocephalus and hopefully identify those patients that are actually in shunt malfunction? This is how we're doing this, and our workflow is such that we're able to calculate hyperfine volumes for these ventriculars using their system. So where the hyperfine image, it goes up to the cloud and to the company, and they're able to deliver this back within 15 to 20 minutes with a calculation of ventricular volume that gives you a number that says that, as you can see there, the left lateral ventricular volume and the right lateral ventricular volume. And it's important because it's, at this point, it's not for diagnostic use, because I'd like to make sure really clear points. The ventricular volume calculations are not FDA approved at this point, but the use of the Hyperfine is for pediatric patients. This is important because what this does is this gives you a very objective measure for, is there a change in ventricular volume? And I'll cover what that means and what we're using to study this a little bit later in the talk. And we're comparing this to standard ventricular volumes. And this is coming from a slide coming from Washington University in St. Louis, showing a 9-year-old subject using standard of care imaging, which we're segmenting and actually using to calculate our ventricular volumes using standard of care images that are all delivered from the 3 separate sites of our study to WashU for calculation. This is important because we have to compare this to the gold standard. And what I believe we're going to end up seeing, but again, the data remains to be shown, is we're going to see that there's an equivalence, and we're able to detect with this those patients that are having changes in ventricular volume and correlate that with our change in symptomatology. So what has Hyperfine done for us? So as those of you that are present within the hospital, there's the MR techs and there's becoming a reduction in the number and availability of MR techs and a reduction of the availability of MR time. So what I have in my clinic here at Nationwide is there's a scanner located in there, a scanner located in the clinic room. So I can see patients both that are getting scanned or need to get scanned and those that are not. We have a total scan time of the imaging that we're currently using for imaging of ventricular volumes of over 13 minutes, which is 2 separate scans. Parents don't leave the room, which is especially important in pediatric patients. And also, because we're having such a problem with a number of MR techs that are currently in the hospital, MR technicians are not required to run the scanner. We actually have our nurses that are present in clinic running the scan and able to deliver images or produce images that are usable and that are capable of being used to calculate ventricular volume. Total time from consent to scan completion is less than 30 minutes. So it has a very limited impact versus all of are those current volumes where you call down to MR scan and they can get you in later that afternoon. So a patient that's seen at 10 o'clock has to wait till 3 because their limited MR scan is having to be fit amongst all the other scheduled cases. It's important because for families that are having to come back on a routine basis and may travel from 2 and 3 hours away, it's from a convenience standpoint, it's extremely important to be able to image them, determine whether you have a clinical problem, and then either get the patient on their way or get them to the OR so that you can really provide the definitive care. This convenience for the patient is exceedingly important. This is a patient that we scanned at Nation. There are limited safety concerns in these kind of particular patients. I can place my reflex hammer on the top of that scanner with no problem. There's no shielding required for doing this. There's a potential for immediate feedback for ventricular volumes, and for that matter, you can look at the scans and compare them to their baseline scans or when they were not having problems to really answer the question for the family that is this an increasing ventricular volume? And more importantly, as I keep emphasizing, the hope here is that we continue to reduce the needs for CT scanning for these patients. Now, this is exceedingly important because as this guy, I believe, was only 10 years old. And when I asked the family sort of what we were going to do, they were like, absolutely, I'm going to participate because I do not like all the CT scans that we're having to perform on him because this is something we're going to have to follow as he gets later on in life. The other thing that Hyperfine has to do is it has to be, you have to determine whether you can, where it is in relationship to the shunt. We have to also be able to determine whether these things are necessary for alternatives to shunt placement as well, including ETV, aqueductoplasty, if you determine that you're going to want to place, and you have to be able to navigate from this as well. And you can do that with some of the volumetric scans that are done using the Hyperfine imaging platform. Now, so what have we done? So let's talk a little bit about preliminary results. We've imaged over 30 patients at Nationwide during the time it's been open. We've imaged a total of 22 valves, 5 of which are adjustable. So we're able to see there's very minimal artifact in these particular patients. We have had to adjust 1 Codman valve during this time, but all the others have not been. So I believe at the end of the day, if you're asking my personal opinion, that we will not, the Certus valves and Strata valves will not have to be reprogrammed after the use of this imaging study, but we have to wait until we have over 200 of these to be able to state that for real. We'll talk a little bit about an example case. So, because I'd like to also show you how we're potentially going to be using this. This is a 10-year-old with polymicrogyria. Before the hemispherectomy, he was having 50 to 20 drop seizures per day. He had underwent a right-sided hemispherectomy, no seizures since surgery, but has several months of progressive headache. They've been trying conservative measures and other things, and comes in with this ventricular scan. There's no evidence of papilledema. So the question at this point is, what are the next steps? So what we did here is we did hyperfine imaging and showed there you can see the presence of the third ventricle. You can see the dilation of the left ventricle on the good side. You can see what's left of the ventricle on the area that it had the hemispherectomy on. So the question is, does this child need a shunt? There's no evidence of other signs of elevated intracranial pressure. I'm repeating the MR scan, and as you can see, this corresponded very well to the standard of care MR images here. You can see the dilated left ventricle here, and you can also see the presence of no temporal horns on the standard of care limited MR that we did as well. This is important because what you're seeing is the hyperfine imaging are providing the same level of imaging quality that we can see with our standard MR images. And this was an older 10-year-old, so it was quite easy to get it without sedation. These were done within less than 30 minutes, and they were able to get on their way. Now, I should also say, until we're able to see this, we're not making any clinical decision, but using these volume calculations. But that's what we hope to see, is to really put definitive numbers and see how these ventricular volume changes over the course of time frame. Another one. This is why it gets rather complicated in pediatrics, is because we can have dysmorphic ventricles like this. This is an 18-year-old with a left parietal encephalocele, a single syncopal episode, but it's had 2 weeks of persistent headaches, nausea, and emesis since this time. Now, as you can see, there are no seizures, no focal deficits. So again, the same questions, hyperfine imaging. You can see the temporal horns are quite small. The third ventricle is slit. So what's the problem here? The problem here is that we have no evidence of elevated intracranial pressure. We continue to have these headaches, nausea, and emesis. We have no change in ventricular size. And obviously, and I'll just get to the point, no changes in ventricular volumes as well. And what we did is image them and compare them to head CT, is my favorite yet again. Head CTs showing the same exact ventricular morphology, the same exact lack of ventricular dilatation, yet expose them to radiation, putting them at increased risk for secondary malignancy, something I am dead set on trying to avoid. Now, this is a case of my worst nightmare. So what we're seeing here is hydrocephalus is a chronic disease. If you're not able to limit the number of surgeries, if you're not able to limit the chances of needing repeat imaging, you're going to get something like this. And this is something that's currently being followed in our practice. And they actually, I kid you not, have 5 both indwelling as well as abandoned ventricular catheters present within their ventricular system. Now, this is, when it gets really bad, this is what happens. What this illustrates is that imaging changes are necessary, i.e. reduction in radiation dose. This child had 40 CT scans by the age of 12 years old. We must change the way in which we treat these, because this is an exceedingly, as this gets more complicated, this causes increasing burden on the children, the parents, and it has a significant public health impact. Hyperfine can and does provide a workaround or an imaging substitution that can really change the way in which we can make it far more convenient for them. We are determining what we see with these kids, because we want to make sure that we do look to demonstrate that the data on ventricular volumes is equivalent, and our ability to detect shunt malfunctions is the same as well. Because this is also a worldwide problem too. And as you can see, both in Asia and Africa, because of the increased incidence of hydrocephalus due to spina bifida, we have to be able to image these folks, and we can really have a significant public health impact if we apply it correctly. with that, I want to thank you very much, and be happy to take questions at this point.
Jeff, thank you very much for that fascinating and enlightening talk. There are a variety of questions from the audience. First, I'd like to say that it seems to be a common theme. Upon processing of the webinar, everyone will get a link so that they can view the webinar itself. In addition, I just want to make one point of clarification, and that is the imaging post-processing algorithms to assess ventricular size, while not cleared in children, so any patient under the age of 18 is FDA approved for adult use. Just want to clarify that again.
Yeah, understood.
Dr. Leonard is a pediatric neurosurgeon, so hence his
Sorry about that.
desire for that. So we have some questions from the audience. First question is, now what do you feel is the place of modern low-dose CT in children to minimize radiation dose?
Modern low-dose imaging does have a place, and it reduces the risk. I will say this, we still get secondary malignancies even with the use of and I've actually published an article that has 2 cases of secondary malignancy. At Washington University, we were one of the early adopters of it. And we have patients with secondary GBMs that had some of these low-dose CTs. It's not, it doesn't, you don't escape the risk, you can reduce it. But it is, the avoidance of that is what I'm after. Let's put it that way. Eddie, you're on mute.
Sorry. The next question relates to uploading images into Stealth or other neuronavigation systems. From a vendor standpoint, the images are 3-dimensional, anisotropic, and can be incorporated into neuronav systems. So the question more specifically is, have you been using Stealth or BrainLab or whatever in some of these cases using Hyperfine data?
I have not yet, but it can be done.
Okay. Next question relates to the reprogramming of ventricular shunts. And there's a question, how often has that been done? I think maybe some of that was covered. And related to that is...
So to be clear, I want to make sure that this is preliminary data with 30 enrollees. I've only had 5 programmable shunts. I've had to reprogram a Codman, which, for those of you that know what shunts are, that's one of the higher risk ones of being moved. The Certus is probably the strongest, as well as the Strata 2. Those I have not had to reprogram, but I want to make sure that I'm not willing to state that until we get far more valves. And I am testing this both before and after the Hyperfine MR.
Great, because there was a question similar to that asking about the need for X-ray follow-up to assess lack of change in shunt programming, but I think you've taken care of that. So kind of a very important question. There are 2 questions that are related and basically relate to the use of point of care MR and how is it benefiting or affecting your overall practice, both in general as well as assessment of shunt failure.
So how will it? I think that...
How will it? How is it? How do you envision this?
Well, I think number one, we have a significant problem with availability of MR techs. They are all, in this current pandemic, they are all going to adult facilities because they pay more. And it's creating a significant backlog, and our throughput is a significant problem. And number one, Hyperfine is going to help that. And Hyperfine is going to help that because about 30% of the volume of our MR volume is for hydrocephalus. And so we're going to just take that off the table because Hyperfine, we're going to be able to use that to image our patients. And really that's going to provide availability across the board. Number two, it's going to be exceedingly more and more convenient for patients and less impactful. I have a number of patients that travel 2 and 3 hours. So it's exceedingly important that when they come here and they have headaches and been having headaches for 2-3 months, and I'm like, I haven't imaged you in over 2 years. I'm going to have to get an imaging study. Now, if I can't get it for another 3 or 4 hours, then they have to drive back to Kentucky. That's a problem, especially, and it's you want to make sure that it provides a level of convenience that's important. And number three, there are some situations where, say, if you come to the emergency room or you come in the middle of the night, you may not be able to get an MR because there's not an MR tech in-house or an MR tech here. So if you have to determine whether you have a shunt problem or not, how are you going to do it? You're either left with a CT scan or the Hyperfine MR. So our hope is that we can remove the need for CT scans in those situations and use a Hyperfine MR to address it.
That's great. There's another question.
And I'll give you one last one. I just thought of the last one. So when I came here, I'll give you a little. This is actually for the radiologists will be a little bit of a funny thing. Is we used to not have MR techs weren't in house, so you have to call them in on call. So I had a patient that had occipital headaches. And child had a KRI2 malformation. Okay, it was a myelo patient with big ventricles. So I originally said, okay, fine. I'm the new guy, and I come in, and on Saturday I'm like, I need a limited MR because I need to evaluate, are the ventricles bigger, or do we have a problem with a KRI2 and I need to decompress it? Because it could have been the way this child was presenting, it could have been both. And they said, well, we can't get a limited MR, we're going to get a CT scan. And I'm like, no, I need to look at the posterior fossa. I need to have the detail of that, and I need to compare it to the other MR scans that this patient is having. So we're able to get the limited MR scan, but Hyperfine completely makes that go away and allows you to allow that ability to use some of your clinical detail that you can see in an MR image that you can't necessarily see in either an ultrasound or a CT scan.
Great, thank you. So we've talked about pediatric hydrocephalus. There's a question relating to what other utilities do you see the Hyperfine scanner in the setting of pediatric neurosurgical patients?
Well, the reason I talked about hydrocephalus is that it's the most common. It's the biggest portion of, depending on where you're practicing. It can be used in, let me give you one, and I know I presented to you guys a few times, is a detection of blood. Right now, non-accidental trauma comes in. You have to determine in these young kids, whether they be 0 up to 2 years of age, where they can't tell you whether they've been abused or not. You have to determine whether you're looking at enlarged subarachnoid spaces or blood and subdurals. And the sensitivity gets pretty, when you get to low field MR, you actually get pretty good sensitivity for detection of hemorrhage. So you may be able to use these and eliminate the use of CT scans in these situations, because again, these children don't normally come in when it's 3 o'clock in the afternoon. They come in at off hours. And again, if in a lot of situations, especially in the non-big institutions, there's no MR techs in house at that point. So what is the ER physician going to do? They're going to get CT scans in that situation. 2, you're also going to have to use this, and you can use this using arachnoid cysts, another very common thing that we can see. You can look to see as it gets better and better, you can use it in tumor imaging, tumor follow-up imaging, where right now we're having to do, our MR scans are thousands of images long. Now, are all these images necessary? I would argue no. But as we get our resolution, we're going to be able to use this in following for pediatric neuro-oncology and reduce the number of sedations, reduce the time that these patients have to spend in the hospital, because you're going to have to image them from 8 to 10 years, depending on their diagnosis and whether they received adjuvant therapy. So I think this can have widespread implications. And I think it very shortly is going to have widespread implications throughout the use of pediatric neurosurgery.
Great. Question regarding specifically the study protocol, your imaging protocol for these patients. What are you routinely doing? And is it
right now it's
what you're suspecting?
What?
And is it varied based on what your clinical suspicions are?
Well, right now I'm being very specific. That's why it's less. There's a 3-minute and a 6-minute scan. It is the scans that we use to calculate the volumes on, and they are rapid. And we're trying to get those volumes calculated on the rapid 3-minute scan, because the faster we do it, the less we have to use sedation for. So what we're currently doing is using this on even the young 0 to 2 years of age, because we want to make sure, if I'm able to eliminate the use of sedation in these kids, it's exceedingly important and very convenient for them, because but we have things, we have volumetric scans, we have sagittal scans, and if I have a teenager in, I can do the same level of detail and scanning that you can see in a standard MR scanner. It's just not going to be done in it's not going to be done in 10 minutes. It's going to take the 30 minutes to end up doing it. So that I can choose based on the level of detail I need.
Gotcha.
But for this particular study, it's just a couple of brief T2 images, because the focus here is calculation and determination of hydrocephalus.
And for that calculation determination, your comparator is a rapid
Standard of
MR or CT, whatever it happens to be?
It is whatever it happens to be, and we have a number of each, because I think we have to demonstrate, and we'll have enough when we finish our study. And I didn't spend enough time on it. I'm sharing my screen with the specific names. What are we currently studying? And we're studying both the radiology reads as well as the ventricular reads, and comparing those to standard of care imaging. So we'll have both available, and we'll publish on both once the study is complete.
Gotcha. Question there are a couple of general questions regarding MR safety. Obviously, from the radiology community, we're all used to screening for MR safety regarding this.
Mm-hmm.
What exactly are you doing? And obviously, these are pediatric patients, so the issues may be slightly different in terms of how do you view this? Is that affecting scanning patients?
Yeah, right. We are screening for everything. We are doing exactly the same screening that we're doing for our standard of MR imaging. So we have not adopted that. We have not shortchanged that protocol or anything else. But the reality of it is, we don't have any safety concerns. I mean, to be frank, I want to make sure that this is first. This is very early on in the study, and we've just opened it up for the other 3 sites. And we will in very short order, we will have a large number of devices that we'll be able to study and report on once the study is complete, or later this year.
Gotcha, great. Just to reiterate on the visualization of artifacts secondary to the valve reservoir mechanism, and there's a couple of questions related to that. You touched upon it. I think it's worth a little reiteration. Yeah,
there is essentially even less artifact than we see in standard of care imaging.
Great.
So I think one of them does have it is much smaller than we see of standard of care imaging. So it is essentially non-existent.
Okay, great. Related to that, there's a question about visualization of the ventricular catheter, determining appropriate location and whatnot. Have you had
it's the same as standard of care imaging. Standard of care MR T2, it's hard at times, and we see the same difficulties that we see in Hyperfine. It is equivalent in my book to standard of care MR imaging. CT will always be best, but it's usable with all. And again, you're seeing some limitations because all I was able to do is put up a few sections during this, but I can see the catheter fine in a number of these imaging studies.
And when you say you're comparing it to standard of care, your standard of care primarily is 1.5 Tesla as opposed to 3?
Yes, we have most of ours are standard of care imaging studies are 1.5. We do use 3 Tesla. I do not have any 3 Tesla magnets because those currently at our institution are reserved for the tumor protocols and radiology protocols. So most of the hydrocephalus is being done at 1.5.
Great. I think we probably covered most everything that's been asked. There was a lot of repetition because everyone has the same questions and the same concerns. One last question to follow up, but I think you indicated this. Where do you see the utility of the Hyperfine scanner greater? On the inpatient side, on the outpatient side, on a mixture?
Both.
Okay.
I think it has applications because there are, we have numerous indications where we're going to be applying it. We're going to emergency room. We have patients coming in for abusive trauma that stay in the hospital to get their MRI scans because it's not emergency. You just have to, before you let them go, you have to get your MR scan to determine whether it's right. But what happens if I can have a nurse or a resident roll the Hyperfine imaging study up, get the scan, and they just have to have a safety plan enabled before they go. We have patients on ECMO that can't go down, or you have to really make it a production to go down for imaging studies. We had head CTs. This is an improvement on the portable head CT. we've had head CTs for a long period of time, and that's how they used to image the inpatients in the ICU. But then for those, you would always do 2 and 3 CT scans because you couldn't quite get it correct. And you're just increasing your dosage for these particular patients. This alleviates that problem in that it's very easy to replace the patients in there. You don't have to take them down or transport them and worry about pulling out lines or anything else, whether it be ECMO, whether it be on other types of ventilation that make it impossible to travel. And all of a sudden you get to determine whether you have intracranial hemorrhage or a problem that you need to address surgically or can really help the parents with prognosis. And this also, this doesn't even cover the use of diffusion imaging, which is, which is a part of what can be done with hyperfine imaging as well.
Great. Well, thank you very much. I want to thank you for taking the time and enlightening our audience, and thanking the audience for joining. Thank you very much. And once again, you'll receive a link to the webinar once it's processed for everyone who is registered. Again, thanks a lot, Jeff. It was great.
You're welcome. Thank you.